Hello everyone, and welcome to another Sagely Health webinar. It's been a while since we've done this, but we've got a great topic for today. I'm Jeremy, CTO at Sagely Health, and I'm joined as always by Dr. Jason Sager, MD, founder of Sagely Health. Jason, how's it going?
Going well, Jeremy, and everyone.
So today we've got a topic that I don't think gets a lot of play in the media, and I don't think a lot of people are talking about, and it's something that really can affect the lives of many breast cancer patients. So it's something we wanted to bring a light to and discuss and kind of talk about what this means for patients. And the topic is HER2-low breast cancer. We'll get into what that is and what that means for patients. So to kind of get grounded, Jason, let's start really broad just to get a definition out of the way. What is breast cancer?
Yeah. So no, thanks for asking. Breast cancer is one of the cancer types that arises when cells in the breast go awry, right? And generally this happens in older adults when they have an accumulation. The cells in the breast can have an accumulation of mutations, and we know that cancer is driven as a genetic origin, right? So that the DNA in the cells accumulate mutations or changes that do not allow them to work the way they're supposed to work. As a result of that, those cells begin to change. They keep dividing when they're not supposed to, or they start to move and travel around the body when they're not supposed to. And this really is the origin of cancer. And again, when related to breast cancer, it's happening in the cells of the breast. Best when detected early, because then surgery is possible. But then there's other elements, factors that are really important, and that's when we come to discussing those elements today.
So by those elements, I think you're talking about ER, PR, and HER2. So
Indeed,
let's
I
get
am.
into
Yes.
that. Yeah, what is ER? What is PR? And what is HER2?
Yeah. So historically, and again, we're looking at more than 50 years ago in like the 1960s, the treatment for breast cancer was all the same. It was surgical. Mostly it was mastectomies. What they found is that there were patients when they had their tumors come back, they began to treat with chemotherapies. They started to look at, well, what's causing these tumors to grow? And they found three factors, growth factors, that were very important. Two of these are hormones, right? So estrogen and progesterone. And again, those are healthy. Women need them in order to have regular bodily function. So, to think of the fact that cancer is utilizing these same signals in a way that causes them to grow says, well, maybe there's some way that we can then target these in a targeted fashion so that we can stop the cancer from growing. And again, in older women who have gone through menopause, the role of estrogen in their regular bodies is less important. And the fact is that when they have cancer, we can use estrogen and hormone blockade in order to stop the cancer from growing. So that's two of the three. The third is one called HER2. And just like the estrogens, although a little harder to say and a little less well known, HER is a receptor on the surface of normal cells and breast cancer cells. But breast cancer cells usually have more of them. They may have it genetically amplified where there's multiple copies producing lots of this receptor on the cell surface. And as a result of this, and also with mutations, these receptors will trigger growth in the cell and division and all of those things that cancer is known for much more quickly than what otherwise would be expected. So at the end of the day, patients who are HER2 positive, meaning they have lots of these HER2 receptors, they had been doing less well up until the point where, again, a targeted therapy called Herceptin was discovered and proven to work in these patients. And that was a great day because now these patients who are HER2 positive were able to get treatment and have a successful outcome for their cancer. The problem is that there was lots of patients who were not HER2 positive, and frankly, some patients, about 10%, who are what they call triple negative, which is they lack any of the three. Estrogen receptor is negative, progesterone receptor is negative, and the HER2 receptor is negative. And we'll talk about why I stress on that, meaning there's not like 100 copies in the cell. There may be several, but not 100. And so that's how triple negative was sort of phrased again, many, many years ago.
Okay, so I might be oversimplifying this, but let me just see if I have this clear. So with ER and PR, we're talking about estrogen and progesterone, which means that that tumor is getting kind of fed by that those hormones are allowing it to grow. And so you have a hormone blockade, meaning I'm going to cut off the levels of that hormone. So hopefully the tumor won't be able to thrive in that environment.
Yeah. And
And
it's
then
more,
with
we know when
her,
it works. Yeah.
and then with HER2, it's a little different. It's that there's certain receptors on the tumor that are there in such numbers that might be something that can be targeted. And when you mentioned Herceptin doing that, it's because there are this number of receptors on the tumor for HER2.
Right.
So before we talk more about that, how does every breast cancer patient get tested for this? How does the test actually work?
Yeah. Yeah. And the good news is that by and large, almost every breast cancer patient will be tested for these three. Even at any time there is any risk for the tumor coming back after surgery, then patients will be tested for this. And in the case of that hormone blockade, especially for patients who are postmenopause, the side effects are fairly well manageable and tolerated. So we know patients who will be put in onto hormone blockade after surgery. Tamoxifen, for example, is very common, and women will be recommended to take tamoxifen for 5 years. There's other drugs as well, letrozole and others that are similar, and these all prevent the cancer from being fed by estrogen, and therefore have done well both in patients who have estrogen receptor positive breast cancer, as well as patients who have surgery but have a risk of it coming back. And that risk is lowered by taking those medicines.
So triple negative, if someone is negative for ER, they're negative for PR, and they're negative for HER2, that's kind of a bad situation because that's just cutting off treatment options. Like hormone blockades may not work, and whatever drugs targeting HER2 won't work. Um, Actually, let me move. So that's really important. So if someone's triple negative, that kind of means that their treatment options might be less than someone who isn't negative for all of those things.
It,
Um,
it's absolutely
Besides,
correct. And again, you know, oh, sorry. I just wanted to mention that that one of the important things that we didn't talk about so far is chemotherapy. The traditional sort of, adriamycin, cyclophosphamide, taxanes, these all exist. And in triple negative breast cancer, because we don't have those other treatment options or haven't had those other treatment options, really chemotherapy is the standard. And unfortunately, it works okay. But if it doesn't work, there's really no other options, or were very few other options available way back when. There's always clinical trials, and we recommend patients look into clinical trials. But we're here today because of a new discovery, and we can talk about how HER2 negative breast cancer was somewhat more redefined recently with the discovery of a new treatment called Enhertu. And so we can talk about why patients who were classified as triple negative actually now can have a treatment option that's really for HER2 positive cancer. But again, they've been told they're HER2 negative. So it's really confusing, and yet really important for patients to know they need to ask their doctor more about this new classification called HER2-Low, by saying, "Doctor, am I HER2-low?" Especially if they hear the words, "You're HER2 negative," then they should ask, "Yes, but am I HER2-low?" And so we'll talk a little bit more about that.
Yeah, before we jump into HER2-Low, which is kind of our main topic, I wanted to just ask about the the characteristics of HER2 positive breast cancer. Because I've read that it's more aggressive, or can be more aggressive. So is that true? Is that kind of how it's understood? And that's why it was kind of such a breakthrough to find something that targeted it, because those people were kind of really
Yeah,
suffering.
yeah. And, and again, we could see this in following patients and just watching how many of them, let's say, compared to, HER2 negative. If you had lots of HER2, patients wouldn't do as well. They would pass away faster of their cancer and it would grow. And so that's where the aggressiveness came from. They have a worse prognosis or a worse outcome, is what they said. Now, that was before Herceptin. After Herceptin, they actually have a better outcome. And so this is where sort of the, by finding these targeted agents against, these genes really makes a difference in patients' lives. So that was exciting, very exciting from the beginning.
Yeah. So you said a really important thing there, which is like how much HER2, and I think that that's really important. That it's not an it it's becoming very clear that it's not an end or, it's not positive or negative, it's a range, and therefore we're
Yeah.
kind of talking about low, but it's kind of so just to, I looked up a couple of the dates, right? So the estrogen receptor, was discovered in the late 1960s, and then in the next decade, the PR receptor was found, and then the early 1980s, HER2 was discovered. That didn't mean they had a medication. Herceptin came later, but in the recent years, we've had a kind of this newer discovery, and that's what we're talking about today. So, can you explain what HER2-low is?
Yeah. Yeah. So I'm going to tell a little bit of a story here, which is that even in the days of Herceptin, patients would be defined as being HER2 positive and negative. I mentioned maybe they have 100 copies or they're genetically amplified for HER2. And there's ways of looking at that in the tumor and seeing that. There's two tests. One is a genetic one. The other one is a protein test called IHC, immunohistochemistry. And there, doctors would, the pathologists would stain the cancer cell. And if there was a lot of HER2, it would be dark. And if there was a medium amount of HER2, it would be like lighter. And if there was no HER2, it would be negative. So from this, they came up with a category of saying, well, there's 0, 1 plus, 2 plus, 3 plus. And so if you're a 3 plus, or if your genes were genetically amplified, then you were considered HER2 positive. But if you were a 0, 1, and 2, you were negative. Now, what was interesting is everyone knew that a few of those patients actually responded to Herceptin. So we're like, huh. But no one really ever tackled trying to do more with Herceptin than to treat the HER2 positive, those 3 plus or amplified patients. Another company, Daiichi, came along and developed a drug to do better than Herceptin. This one is called Enhertu. And the way that they did better was by taking a similar antibody on one side as Herceptin that would attach to the HER2 protein, but they put on a chemotherapy toxin on the other side of it. So basically, you were delivering a toxin directly to the cancer cell. And this worked better than Herceptin. And so in HER2 positive patients, they were benefiting even more than they were benefiting with Herceptin. And so Daiichi and HER2 said, well, that's great. But now they started to look at those patients that were quote unquote HER2 negative, right? Those triple negative breast cancer patients. And they said, well, what if we take patients who were not just 3 plus, but took a look at the 2 plus or the 1 plus patients? Will they also respond? And the answer was yes, robustly. And so now all of a sudden, you've got a situation where medicine and science has sort of designated HER2 positive and negative based on a one characteristic, and all of a sudden a new medicine has had a breakthrough where they have to kind of redefine it, but they only have to redefine it for that medicine because the other medicine, Herceptin, still only is for HER2 positive, the 3+ers. So the world gets quite confusing. To try to settle that out, the term HER2-Low came about. And so now there's the HER2 positive, there's HER2 negative, and true negative is zero, right? There's no expression. But now there's the 1 and 2s that are in the HER2-Low category. The problem is that patients will hear all the time, and doctors will hear if the patient's HER2 negative or positive. But unless they ask, they won't necessarily hear if they're HER2-Low. And that's why we're doing this today, because we want every breast cancer patient who hears that they're HER2 negative to then ask the question to their doctor, Doctor, yes, but am I HER2-Low? Meaning, do I have that 1 or 2 plus? And could I benefit by that drug in HER2? Or other drugs, and we'll talk about that in a moment, coming down the pike that are targeting that HER2-Low classification.
And it's not insignificant, the number of people who are HER2 low. So do we have some type of percentage of the millions of breast cancer patients who have been told they are, HER2 negative? What percentage of those are more likely to be HER2 low?
Yeah. So first of all, if we look at all breast cancer patients, about a quarter of them, 25%, are going to be HER2 positive, meaning that really high, HER2 high. Of the ones that are negative, right, which is all of the ERPR positive and HER2 negative, or anyone who's triple negative breast cancer, 60% of those patients are going to be HER2-Low. So it's not a small number. It's actually
Yeah.
quite a large number. And that's where it's really exciting, because now there's a whole avenue that was never available before besides chemotherapy to use for these patients. And that's why, again, we want every patient to know about this.
So how would someone who was told they were HER2 negative go about finding out if they're actually HER2 low?
Yeah, I'd say, we at Sagely Health, we believe strongly in proactive patients. And so from my perspective, again, it starts with that question to the doctor, to the oncologist, say, well, doctor, I understand I'm HER2 negative, but I heard about this new thing called HER2-Low, and I want to know, am I HER2-Low? See what the oncologist says. They might need to look it up. I think a second avenue is to actually ask for the report, the pathology report that was done on the tumor, because again, that's where the staining will say, and they'll give an interpretation, but they'll also tell everyone what they did, and they'll tell you the actual results of the staining itself. And so they might say this patient had 1 plus HER2, and then they'll say interpretation HER2 negative. But again, if patients, or we can help patients and others can help patients to understand and interpret those reports and identify that HER2-Low status.
Do you think that, I mean, I've heard you maybe answered this already, but do you think patients and more importantly, oncologists are kind of aware of this classification and are bringing it up with patients?
Yeah, I mean, they certainly should be, and I hope that they are. I'd say that probably more oncologists than patients are aware of it, but that's why we want to make sure, because we've certainly seen cases that have slipped through the cracks, where either an oncologist says initially that the patient's HER2 negative, and then maybe later when the patient needs, let's say the tumor comes back, and the oncologist only remembers the HER2 negative part, forgets to relook it up and see if they're HER2-Low, because maybe this happened even before and HER2 was available. Could have been 20 years ago, right? And so from my perspective, that's where we see a number of patients sort of falling through the cracks. So to me, the best way to ward off against that is by having patients who are proactive and remind their doctors to kindly check, are they HER2-Low?
So if you have that conversation, whether that's a conversation with your own pathology report or with your oncologist, and you do find that you're HER2 low. What does that mean for your treatment options, including like, are there clinical trials that are exploring treatments for HER2 low right now?
Absolutely, absolutely. And so, as I mentioned before, there's a there's a medicine called Enhertu that was created specifically for this category of patients. That led to the definition of it. And so that's that is one treatment. And and I did in advance of this, I did a quick search. When I looked for this, HER2 low status, 27 therapies 27 trials popped up in our system. Um, when looking at some of the results that tag that HER2 low, you can see some of the medicines coming up. There are certainly, and you'll see them all HER2 directed CAR T. This is an immunotherapy that's against HER2. I want to show you this one down here because this trastuzumab deruxtecan, that's a fancy name, or actually the generic name for Enhertu. So indeed, this is the actual drug itself. And now what they're trying to do here in this trial looks like they are combining this drug with another drug, which is an EZH1 and 2 inhibitor. And so they're going to ask the question, do patients, we already know that patients who get Enhertu, the trastuzumab deruxtecan, do better. And this is with patients with low, ultra low, or null, and that's the 0 metastatic breast cancer. But now can we do better in this combination with patients who have EZH1 and 2 inhibitor as well? And so, there's others. I mean, this is a bispecific um, that attacks two targets at the same time. So, the fact is that yes, I think there's a whole world of therapies out there for patients, which really is a new avenue, especially for triple negative breast cancer patients. So, we encourage every patient at every step to check and see what clinical trials might be right for them, especially patients who have high risk of the cancer coming back or who have metastatic or advanced cancer already. But this is certainly a very important avenue, and quite excited about it.
If there is a patient who has in the past had surgery for breast cancer, they've had a tumor removed or lumpectomy or mastectomy, and I mean, just at any time a woman has breast cancer, she's then kind of lives in this fear of recurrence. And I think that, and you said that the testing for the ER, the PR, and the HER2 will be done if they're high risk. So it sounds like there are situations where the removal of the tumor is kind of so straightforward they may not do this testing, but in most
Right.
cases they would.
I'd say almost all, but yes, there's
Okay.
if it's really quite small and just needs a lumpectomy and nothing else, then fine. But as soon as a patient's getting surgery and radiation, or surgery and some in some sort of prophylaxis, then yes, that's how they're determining what that should be.
I just so this may become very important if this person never does have a recurrence. And I think that you pointed out that the length of time that can happen in the recurrence is really varied. A recurrence can happen very quickly,
Mhm.
or it can happen many years or even decades later. And so it's probably, I mean, anyone listening, I think it's, good to talk to anyone who's had breast cancer to say, this might just be worth knowing, just in case, so that this is kind of top of your mind to talk with your oncologist should you end up back in that office after a scan, or kind of an increased level or something like that. Is that a fair way to think about it?
Yeah, absolutely. And I know that, patients will be monitored annually with mammography and this sort of thing to make sure. Again, sometimes the cancer spreads. So yes, and again, the chances do get lower every year. So there's sort of a long tail, and so the longer you're out, the more assured you can be. We don't want people to be super nervous about that, but the fact is that tamoxifen will go for 5, and then with all the other medicines, 10, Some patients take it for more years than that. So it is a long time that patients will be on guard to watch out for recurrences. And as such, we want to make sure that they're talking to each other about this new HER2-low entity and definition. And Jeremy, I'm
Well,
going to
great.
introduce one more fact. Well, I got one more thing, which is that
Go for it.
it's not just breast cancer. HER2 actually happens with other cancers as well. And so, again, we believe all patients should have a next gen sequencing test on their tumor called a genetic analysis, next gen sequencing. And there's a number of companies that do it. But we believe every cancer patient, again, especially if they're a high risk or having advanced or metastatic disease, they should have next gen sequencing because HER2 will be in there. And again, for patients who have gastric cancer, for example, and we know of a young man with gastric cancer who's HER2 positive, and he's alive today because of all of the breast cancer medicines. But they're using them in his gastric cancer because he's HER2 positive. And, in even more so, we start to think about how complex things are. But if you get that HER2-low in another cancer, it's not yet proven. But it would be a pretty good idea to think about using Enhertu in those patients. We had a patient with lung cancer with a HER2 change, and that led to 4 years of great successful treatment. So, again, it's not just breast cancer, but all cancer patients should think about HER2. And every breast cancer patient who knows another cancer patient who doesn't have breast cancer should make sure that they get next-gen sequencing done and know to ask the doctor about HER2.
It's a great point. I mean, I just say, at Sagely Health, you've mentioned it already. We're going to ask every single patient, have you got next gen tumor sequencing done? If not, have you had a ctDNA test done? We want to kind of know what's going on in the tumor, in your genetics. I also want to underline that the NCCN says the best treatment for any cancer patient is in a clinical trial. So clinical trials should be considered at every treatment point. We're seeing here that there are potential innovations happening for patients who are HER2 negative or HER2 low, and those are HER2 positive. So it's something, and that's what we kind of do at Sagely Health, is make sure people reach these types of treatments. Jason, so I guess in the end, I mean, let me just ask you, what advice would you have to someone who has been told that they are HER2 negative in the past? What should they be doing today?
Yeah. So again, just like we've said several times already, but love to say it again. As soon as they hear that they're HER2 negative, the very next question should be, yes, doctor, I understand. Am I HER2 low? Do I have a low amount of that HER2? And can you help me to understand that from my pathology report? And so that's really the question that I want every cancer patient, every breast cancer patient for sure, and then many other cancer patients as well, going into the office and hearing. As soon as they hear HER2 negative, then they say, or triple negative, then they say, am I HER2 low?
Great. Well, I want to thank everybody who's been listening, everyone who submitted questions. If you do have further questions about anything we've talked about here today or in any of other webinars, please reach out. It's sagelyhealth.com. We have a contact form. You can find us on the social media. We're available to answer any questions, and we're also available for personalized consultations. Any final thoughts, Jason?
No, I think that's it. Thanks so much, everyone.